Everyone. So today's topic given to me is PSVD, histological spectrum and outcome. So the outline of this presentation will be, I will start with few cases and subsequently a brief introduction to the both terms like NCPH and PSVD, and then histological spectrum and outcome based on histology. So before I move to the cases, please remember this. This is the normal portal tract, and this black line, dotted line, is a limiting plate. And this is a portal stroma, which is silent, not showing any inflammation, not showing any myofibroblast activation. And this is the hepatic artery, or of similar size of hepatic artery, there will be a bile duct and a portal vein, which is larger than these two structures. And the sinusoids are the structure which are between the liver plates, and they are also not showing any inflammation. This is a normal portal tract and normal liver parenchyma. Now, coming to the first case, this is a 42-year female. She had portal hypertension and small varices, esophageal varices, hypersplenism. ASMA was positive and IgG was raised. LFT was relatively normal, and the clinical diagnosis was CLD, query AIH. And this liver biopsy, this is a fragmented liver biopsy. You can show multiple fragmented fragments, and they are not showing any inflammation, no steatosis, nothing is there, no fibrosis. So it is a relatively silent biopsy. Again, higher power view, you can see some of the portal tract in the Mason's trichrome, and they are not showing any extension of fibrosis, no inflammation, nothing is there in the parenchyma. Further high power view, you can see three portal tract. These three portal tract, you can see artery, duct, but not the portal vein. So this is the fibrotic portal tract. It is not showing any portal vein here. This is another portal tract not showing the portal vein structure, and this is the third portal tract. These are proximated to each other, and there is no inflammation in the parenchyma, nothing is there, and the portal tract are also silent. And the portal veins are not visualized in these two portal tract, where in this it is an arterialized portal vein. This is a large portal tract here. It is also showing arteries, two arteries, ducts, and this is a portal vein which is attenuated and showing the muscularization of the wall, and that is called arterialized portal vein. So the diagnosis in this case was obliterative portal venopathy. The second case is 31-year male, portal hypertension, dilated SP axis, grade 1 esophageal varices, ANA positive, IgG was raised, and the liver function tests were normal. The differential diagnosis were CLD AIH versus NCPF. And this is a low power view of the liver biopsy. You can see again, these are two portal structures here. They are not showing much of inflammation, and they are expanded as compared to the previous biopsy we saw. And the liver parenchyma is not showing any inflammation, no steatosis, nothing in the liver parenchyma. In a higher power view, you can see the portal tract, the very well defined limiting plate here. This is a hepatic artery, arterioles. This is duct, and this is also a duct basically, and this is artery, not showing any portal vein structure here. But the fibrosis in this portal tract is bit expanded. It is going into the parenchyma. This is another portal tract, also showing similar features which we discussed in this portal tract. But here there is an attenuated portal vein which is showing some arterialization, and the liver parenchyma is unremarkable. In Mason's trichrome, you can see the extension of fibrosis going into the parenchyma, apart from the attenuation or the absence of the portal vein, and in other areas also it is showing. And one more thing, the central vein structure was patent. Usually in cirrhosis, we don't see the portal vein structure because we used to read in Robbins that there is a connection between the portal and portal central structures. So the diagnosis in this case is obliterative portal venopathy with increased fibrosis, because the fibrosis was going into the parenchyma. The third case is 43-year male, LFT were normal. He had right heart disease. LSM was 8.9 and HVPG was bit higher, and CT showed a dysmorphic liver with portal hypertension features. And this is the low power view of the liver biopsy. You can see again the parenchyma is silent. It is not showing anything here, and there is a structure here. It is going across the and creating some nodules, incomplete nodules, which we will see in the Mason's trichrome. The nodules here are formed by very thin fibrous bridges, and they are broken and they are blind ending. A very thin fibrous bands here, not fibrous bands, it is a fibrous bridges or thin fibrous bridges which is broken. Here also you can see a bridge, and this is broken, and blind ending, here it is also broken. So diagnosis in this case is incomplete septal cirrhosis. This is a misnomer basically, so it should be ideally incomplete septal fibrosis. Case 4, 19-year male, ASMA positive, IgG raised. He had lymphadenopathy. Liver function test relatively normal, except the ALP and GGT were raised, and CT showed hepatomegaly with nodule formation, query granulomatous liver disease. Here you can see a normal looking liver parenchyma. This is a portal tract. It is showing 3 structures: artery, duct, and vein. There is some nodule kind of formation. Here you can see normal hepatocytes. These are relatively light stained, and this is a structure which is showing bit dark stained hepatocytes. I will show it in the sorry ma'am. Okay. So the dark stained areas, they are showing compressed hepatocyte cord with reticulin condensation here, and here also these are other structure which are showing similar kind of morphology, and they are creating the small size nodules. And this is the another area which is showing the compressed hepatocyte cord with reticulin condensation, and it is circumscribing the normal or regenerating or thickened plate of the hepatocytes. So this is a reticulin stain, and diagnosis in this case is NRH, nodular regenerative hyperplasia. Case 5, a 47 male, anemia, hepatosplenomegaly, CT changes were of portal hypertension, LFT was normal. Here in this case, you can see again the obliterative portal venopathy. A portal tract is expanded, and it is not showing portal vein structure. This is duct, this is artery, not showing any portal vein structure. And the sinusoids here, unlike the other cases which we saw, they are a bit dilated, and they are profusely dilated across the liver parenchyma, and they are not showing any zonal distribution. So non-zonal sinusoidal dilatation here. This is another case also showing non-zonal dilatation and atretic portal tract. This is the similar case which is also showing non-zonal sinusoidal dilatation. So diagnosis in this case is megasinusoids. Now coming to the entity which is NCPH or NCPF, it is a clinico-pathological entity which should have the clinical signs and symptoms of portal hypertension, number 1. Number 2, the absence of liver cirrhosis or known risk factor accountable for the portal hypertension. And the liver biopsy, it will show the changes in the portal vein, preferably the obliterative portal venopathy with or without fibrosis. It should have the clinical signs of portal hypertension, which the clinicians know very well, and it should have the exclusion of the cirrhosis on liver biopsy, and known entities should be ruled out. And also the congenital hepatic fibrosis, sarcoidosis, and schistosomiasis should be ruled out. And then we can say this is a NCPH or NCPF. But the issue is that the similar kind of morphological spectrum which we see in the liver biopsy can also be seen in normal liver with aging and remodeled liver parenchyma after trauma, post-gastric bypass surgery, post-cholecystectomy, and dialysis patients. So similar picture that we saw in case of PSVD or NCPH cases in five cases, we can see in the physiological processes post-surgery or with aging or with trauma. Apart from this, there were some studies which highlighted that the similar kind of picture can be seen without any progression to the portal hypertension in follow-up. So those patients which are showing the features of NCPF or the PSVD may not develop portal hypertension, and they may not have the portal hypertension initially. So by this, these things, there are some limitations in the definition of NCPH, that liver changes that can be present without any portal hypertension, and it suggests that this inclusion of the portal hypertension in the definition is too restrictive, and it may rule out or it may negate the possibility of preclinical NCPH. Portal vein thrombosis is also to be ruled out in case of NCPH, but since it is a spectrum of similar disease, the PVT can develop in cases of NCPH as well. And it requires the exclusion of the other diseases, but the similar features of NCPF can be coexistent with the other parenchymal liver diseases. So the newer term devised, that is the portosinusoidal vascular diseases. So it includes the patients without portal hypertension if histology is compatible, and it also includes the patients with the portal vein thrombosis, and it also includes the patients with the coexistent other liver disease like alcohol, metabolic, or viral disease if the histology is compatible. So purely this is based on the histology, and this was discussed in previous lecture by Satyendra, so previous एक महीने पहले. So but I will not go into the detail, and the liver biopsy is mandatory for the diagnosis, and it should have the absence of cirrhosis plus one sign specific with the portal hypertension and one histological lesion specific to the PSVD. So I'll not enumerate them because the major things we have already discussed in the cases. Now the PSVD also excludes certain entities which can also show the histological features of the PSVD classically, which we see. So limitation, it is also not devoid any limitation. The PSVD has its own limitation, and that this is too simplistic and it decreases the accuracy of the diagnosis. Primarily, it depends upon the histology, and in histology itself, the features are very subtle, and they may not be recognized very well by the inexperienced pathologists or those who are not working in the field of liver pathology. And it is insufficiently precise because of the under-recognized histological features and might introduce the bias. Though it broadens the spectrum, it also includes the condition which may coexisted. So, and yet, the most important thing is the clinical significance of PSVD is not very well established, especially those patients who are without PH, why we should label them as diseased patients. The etiology is primary related to the prothrombotic tendencies. Secondaries, there may be immune diseases, hematological conditions, immunodeficiency, drugs, chronic biliary conditions, gastrointestinal diseases like celiac and ulcerative colitis. So how the evolution of the PSVD become? So this is a portal triad. Here you can see three structures. This is artery, this is bile duct, and this is a portal vein, and this is central vein. Now what happens? There is a obliterative portal venopathy. There will be the obliteration of the portal vein. What it causes? It causes the ischemia of the hepatic parenchyma, and this ischemia ultimately lead to the extinction of the hepatocyte cords, and that name is parenchymal extinction or parenchymal collapse. So your parenchyma is relatively less here with the obliterative portal vein, so we call it as a obliterative portal venopathy. Subsequently, this extended lesion will become fibrotic with the inclusion of the aberrant vascular structures, and once the fibrosis is there, then we will say this is an obliterative portal venopathy with fibrosis. And the fibrosis, along with the fibrosis, there will be a regeneration of the remaining hepatocytes, and they will push the fibrosis towards the periphery, and that leads to the broken of the fibrous and thinning of the fibrous bridges, and then it will call as incomplete septal cirrhosis. And when the regenerative hepatocytes, they will break this apart, and then there will be aberrant vascular structure closer to the proximity to each other, and what you call is relatively thinned out hepatocytes can encircle the regenerative hepatocytes, and then we will say this is a nodular regenerative hyperplasia. So the OPV again, the limiting plate will be normal, and there will be no fibrosis. Parenchyma will be normal. The portal vein will be gone, or it is slit-like lumen, or it is arterialized. Here it is a slit-like lumen. It is showing absence of the portal vein. Here it is arterialized portal vein. Please remember that 30% of the portal tract in normal liver may not show the presence of portal vein. So in that case, we should rely that at least 50% of the portal tract should not have the portal vein structure. Then only we will say that this might be a obliterative portal venopathy in appropriate clinical context. Here there is no there is no inflammation in the portal tract and the parenchyma. The fibrosis extension may go into the parenchyma, and this is a slit-like again lumen of the arterialized portal vein. The second entity which we discussed is the obliterative portal venopathy with increased fibrosis. This is a study which emphasized these kind of patients, and they highlighted that these patients may have more complication, and especially the portal hypertension related complications, those patients which have the increased fibrosis along with the obliterative portal venopathy. Obliterative portal venopathy, to give some amount of objectivity, this is a recent study in the modern pathology which highlighted that the spectrum absence of the portal vein, slit-like lumen, or arterialized portal vein, this is a definitive obliterative portal venopathy. But if these are not seen, only the dilated structures, dilated aberrant portal venules, these will say it is a suggestive or indicative of the obliterative portal venopathy. So the consistent with obliterative portal venopathy is they have highlighted that absence of cirrhosis should be there, absence of condition known to cause portal hypertension, and presence of one of the following: the portal vein narrowing, the obliteration or loss accompanied by increased portal fibrosis, or NRH. So if these findings are there, then we will say this is a definitive OPV. Indeterminate for OPV or suggestive or indicative of OPV is when, along with the absence of cirrhosis, absence of condition known to cause portal hypertension associated with aberrant portal or periportal vessels accompanied by increase in portal fibrosis. So this is to give some objectivity in case of OPV. The third thing is incomplete septal cirrhosis. This is a purely morphological definition, and it is characterized by very thinned out fibrous bands or septa or bridges, which is inactive, not showing any inflammation. Myofibroblastic proliferation is also not there, and these are broken in between, and they are blind ending fibrous septa. Then we will say this is a incomplete septal cirrhosis, and basically it is a bridge between NCPH and true cirrhosis. NRH, this is a atrophied hepatocyte cord. It is encircling the regenerative hepatocytes, and this is called morphologically called nodular regenerative hyperplasia. And this is studied by Archana ma'am, and it highlighted that in case of NRH, the hepatocyte, especially around the central vein, this is central vein, and the hepatocytes may show the positivity for CK7, and also the sinusoids in case of NRH may show positivity for CD34. So the importance of this is that CK7 in the atrophic perivenular hepatocyte, it may indicate the adaptive response of the altered perfusion state in the hepatocytes. And CD34 positivity, which is in normal liver, which is not there, so it might represent an attempt to stabilize and prevent the disruption of the sinusoidal lining in an altered perfusion state, which is seen in NRH. Megasinusoids, So the starting will occur when there is aberrant vascular structure outside the portal tract, or they are going into the parenchyma, and these shunted vessels or aberrant vessels, they will create a hyperperfusion state in the parenchyma, and subsequently it will lead to dilatation of the sinusoids, and these sinusoids may have the fibrosis along with them or may not have fibrosis, and they called megasinusoids with or without fibrosis. And this is the entire spectrum. Again, study from our department, and it shows the spectrum of histological changes. Majority of the histological changes we have discussed, and some lesser encountered, or you can say lesser defined features can be approximation of the portal tract, atretic portal tract, and arterialization, aberrant vascular proliferation outside the portal tract, that is portal angiomatosis, and dilated portal venular structures. They can be less defined in case of NCPH or PSVD. Now, the International Liver Pathology Study Group, it has given certain terms to unify the various histological features which we describe in the pathology report. So they say that portal vein stenosis should be used instead of the flavosclerosis and OPV. Herniated portal vein should be used in case of herniated portal vein branches. Hypervascular portal tract should be used when there is a multiplicity of the portal vessels in or outside the portal vein, and periportal abnormal vessels should be used in place of periportal shunting vessels. This need not to remember. It's just that they come up with these terms. And now certain thing which is related to outcome with certain histological features. So before going that, the previous study where we highlighted the spectrum of the NCPF, in that study the median LSM value was 9.2 and the range was 4.4 to 26.3. So basically, and I'll come to it, and the HBPG, the mean was 9.8 and the range was 5 to 20. कहने का मतलब ये है that the LSM value and the HBPG, they may vary in case of NCPF, and the range is pretty wide. So that means that certain cases of NCPF may have higher HBPG or LSM values. So what are those entities which could be there? So this study, in which we characterized based on the histological feature NCPF cases into the obliterative portal venopathy with fibrosis, incomplete septal cirrhosis, nodular regenerative hyperplasia, megasinusoids, and unclassified. Here we saw that those cases with the obliterative portal venopathy and ISC may show higher HBPG as compared to the other categories, whereas the LSM may be higher in case of NRH and megasinusoids, because basically they are expanding the parenchyma. Both in megasinusoids and NRH there is regenerative hyperplasia, and megasinusoids there is a sinusoidal dilatation. So that may lead to the higher LSM value. And this LSM value, if you see the amount of fibrosis is obvious because the fibrosis is there in OPV with fibrosis and ISC. So the quantity of fibrosis will be more in those cases, and whereas in NRH and MSF the fibrosis is not that much. So the hepatic vein pressure gradient, it will correlate with the amount of fibrosis in those cases, but the liver stiffness measurement, it will not correlate with the fibrosis. So the value of LSM is bit spurious because it is not related to true fibrosis. It is basically because of the expansion of the liver parenchyma or volume expansion of the liver parenchyma. So, and based on the outcome, we noted that portal hypertension related complications were more prominent in case of OPV, F, and the incomplete septal cirrhosis as compared to the other entities which we classified. Coming to way forward, So this is a study which highlighted that there is a heterogeneity in case of the liver sinusoidal endothelial cells. If we go from periportal area to the central vein, so there will be a lot of heterogeneity, and the specific markers which could be of importance is the arterial, which will show the VWF and Kevin 3, lymphatic vessel IL-7, periportal sinusoids will show the CD38 and ADAM23, midzonal ADAM TS13 and CLEC1B, and central THBD and KIT. So that means possibly there might be a possibility that there might be a different sinusoidal endothelial cells which are getting affected because of insult or because of the genetic predisposition. So we need to understand this, that in which kind of like why in certain conditions of OPV there is a fibrosis, why there is incomplete septal cirrhosis with OPV, why there is NRH changes. So there might be it's a possibility, it's a hypothesis that these vessels, different vessels, may get affected in different entities. And to summarize, this both the terminologies has their own limitations. It's a wide spectrum disease and may have role in outcome, and subset of patients may show dissociation between the true fibrosis and LSM and HVPG. Thank you.